sorry, I'm muted.
Oh, okay.
Okay. Who want to present?
Okay, it's okay. I will start first.
Yeah. Are you going to present patient the ward, right?
Yes. But my patient currently already discharged.
Oh.
She just
You design the patient in the ward.
She just discharged. I have clocked the patient.
That's discharged this morning.
Not this morning. I clocked like 2 days ago because recently we just have COVID outbreak, so there are time interval where we cannot go to the ward. So.
See. Okay, fine. You can present now.
So my patient, Rite, 70-year-old, with underlying uncontrolled DM and hypertension. She's a known case of NSTEMI, currently presented with a recurring chest pain for 1 day duration. She was apparently well until 1 day prior to the admission. She started to develop respiratory chest pain characterized as sudden in onset, heavy and pressured in nature, intermittent episode of which it occurred at 1 p.m. and 7 p.m. on the same day, and each episode lasted for 5 minutes. It occurred after she came out from the toilet. The pain was radiated to the left arm, and she had scored the pain as 7 out of 10. The pain is usually relieved temporarily when taking sublingual GTN and rest. However, as the pain getting worsening, she then decided to seek treatment to ED suspect. Otherwise, there's no profuse sweating, no shortness of breath, no nausea, vomiting, no palpitation, and no heart failure symptoms such as autopnea, paroxysmal nocturnal dyspnea, and leg swelling. There was also no URTI symptoms such as fever, cough, runny nose. She also denied of having any syncopal attack, any history of blunt trauma to the chest, or history of prolonged immobilization. And upon further asking, she had developed this similar presentation last time, of which on July 2021, July this year, of which she was admitted to internal medicine ward and was treated during that time as NSTEMI. And during the stay, she was admitted to the cardiac care unit for 1 week for close monitoring. However, she was then discharged earlier, bearing her own risk because of personal reasons. She had discharged with several medications, such as aspirin and clopidogrel, as well as sublingual GTN. And then, upon further asking, she had done coronary angiogram early this month and was diagnosed to have triple vessel disease. And subsequently, she then was planned for a stenting procedure in 2 weeks' time. However, she then again discharged at her own risk and 1 week prior to the recent episode of her recurring chest pain. So,
okay, I'm at my Besakit now. Can you tell me what is the IC number of this patient?
IC number?
Yeah.
Or you want her ID number?
Yes.
ID?
Registration number or IC number? Also.
Okay, ID number 10
10
14
14
233.
233. Okay. Putih
yes.
Manba.
Tenti Manba. Yes.
Okay, fine. So, Karen, no problem.
Okay, alright. Then for her systemic review, it is unremarkable. For past medical history, she had hypertension as well as diabetic mellitus. For her hypertension and diabetes, she had been diagnosed to have hypertension and diabetes 15 years ago and currently at the follow-up at KKIM. For her hypertension, she was currently on bisoprolol 5 mg. For her diabetic, she was currently on insulin, of which subcut atrapid 8 unit, and also subcut insulatide 18 IU on the night, as well as she was also on empagliflozin medication. However, for her diabetic and hypertension, she claimed that she is not compliant to the medication. She also had been diagnosed with dyslipidemia of which she been diagnosed on her last admission, which is this year. And she has been on atorvastatin. She also had gastritis diagnosed 1 year ago at the local clinic, and currently on tablet pantoprazole. Other than that, she had also history of doing removing of the ureteric stone in 2010. In 2018, sorry. For her family history, her parent died due to old age at 72 and 76 years old respectively. No malignancy runs in the family. She cannot recall what her parent is having, any disease she cannot recall. For drug history, she don't have any drug allergy. Social history, she is currently EDL independent. She lives with her retired husband and younger daughter in Indrama Kota, of which their house is occupied with basic amenities. For physical examination, generally she was conscious, alert. She was not in any pain. I have
before we go to the examination, anybody any questions to ask? Maybe I can ask her. Do you think her diabetes is well controlled?
No. You
Why?
ask
Why you say so?
Because during the physical examination, the nurse pricked her finger, and that time her blood glucose was like 13.6.
So are you going to say that this means that the sugar is not well controlled? Maybe she's in the stress condition. That's why the sugar go very high. What else can you tell whether the sugar is controlled or not controlled?
She's also on insulin.
Mm-hmm.
And then from the history, she admitted to me that she's not compliant to the medication. She only takes whenever she wants.
Okay. Any other history that you can tell whether patient diabetes is controlled or not controlled? What other history that you need to ask?
Ask about complication of diabetes and symptom of hyperglycemia, such as polyphagia, polydipsia,
So did you ask?
nocturia.
I have asked, but she said she doesn't have that any polydipsia, polyphagia.
Okay. So what else can you tell? What other history that you want to know from the patients? Other than polydipsia, polyuria, which you asked the patient, say none. So what else can you tell?
Complication of diabetes, such as numbness of the peripheral.
Okay, fine. But sometimes the patient, even very well controlled, they still get complication after many years. Anything else that from the history you can ask the patient? How do you go to monitor the patient's sugar if you are doctors in touch?
HbA1c.
Alright. So do you ask her what's the HbA1c?
HbA1c, I did, but she did not remember.
So how do you gonna dig out the HbA1c if you are seeing patient in the clinic or in the ward? Okay, just to let you know, all the patients who are diabetes, there is these diabetic books. Have you seen the green books?
Oh yes.
The diabetic books?
In KK during my
For all patients who are having diabetes, so you got to ask them for the book. So inside is going to be written what medication patient is taking, what is their blood test result, renal function, UFME, as well as HbA1c, blood pressure as well. So all these will be recorded. Okay, even if the patient got diabetic retinopathy, it will be recorded as well. So you have to ask the patient. All patients have the books. As long as they are in Malaysia, they are under diabetic clinic follow-up, or KK follow-up, even KK follow-up or diabetic in the hospital. So all of them have the books. So you must put initiative to go and get the books from them. So then you can go through and then see whether is it really true that this patient has no polyuria, polydipsia. I doubt so, because her large HbA1c is 9 point something. So is 9 point something good?
No.
Not good. So what is your aim of HbA1c?
It should be
in the elderly patient?
It should be less than 6.5.
Yeah, less than 6.5. Okay. So from there, diabetes is not well controlled. And then, of course, this patient is multiple defaulter, never listen to doctors. So, like you mentioned also, patient never take insulin. Okay, fine. Now, let's come back, ask you this question. Do you think this current admission is angina? Is it angina?
I think it's angina.
You think it's angina? Why you say it's angina?
Because she's having a sudden onset of chest pain, and the duration of chest pain is within 5 minutes, and she has 2 episodes in one day, as well as
all this cannot tell you is I also got chest pain once a while. Yesterday I got chest pain, also last more than 30 minutes, 2 episodes in a day. But I don't think it's angina.
As well as she is a known case of angina before this, so
that also cannot tell you this is angina. It doesn't mean that anybody who has coronary artery disease come with chest pain, they're having angina. They could have having costochondritis, say for example, can be having reflux, esophagitis, So how do you tell it's angina?
Is it because
persistent?
No, persistent cannot tell you it's angina.
I think Aina said that the pain was relieved a bit by GTI.
Okay, that's one characteristic of chest pain. But what's the typical characteristic of chest pain? Angina. Where's the pain?
The pain is retrosternal
Alright.
and radiate to the left arm.
Okay. And also nature or
The
characteristic?
characteristics of the pain, it will be pressure type of pain.
Correct. Okay. Pressure pain or what else?
Heaviness or constricting.
Okay. Do you think this could be myocardial infarction this time around?
It could be
Why you say it could be? What are the characteristics of myocardial infarction?
maybe we can see the ECG first.
No. Before the ECG, just based on symptoms, how do you tell? When I see this patient come with chest pain, typical chest pain, like what you say, retrosternal, pressing in nature, what are the characteristics that will tell you likely this is myocardial infarction?
Maybe it is
Which this patient may not have, but I just want to ask you, how do you tell this is? Associated with what?
Associate with profuse sweating, shortness of breath.
Yes. Not so much shortness of breath. One more very important one.
Effort tolerance.
No.
Nausea, vomiting.
Correct. Nausea, vomiting. Usually they have sympathetic hyperactivity when they got myocardial infarction. Nausea, vomiting, and also duration of the pain. How long it will last? That it tell you likely to be AMI.
More than 30 minutes.
Alright, more than 30 minutes. So duration of chest pain very important. If it's more than 30 minutes, associated with nausea, vomiting, so these are likely to be myocardial infarction. Okay, based on the history. Yeah, of course I know ECG can tell you. Just now you mentioned that this patient had angiogram done, right?
Yes.
And was there any angioplasty done?
Coronary angioplasty she was planning to do, but then she was discharged at her own rate.
I see. Are you sure it's the angioplasty or they are planning for surgery? Because I'm reading the notes, it's actually planning for surgery, bypass surgery. So what are the indications of bypass surgery?
From this patient, because of I think I heard about triple vessel disease, so maybe due to that.
Yeah, triple vessel disease. What else? What else that people will usually do bypass rather than angioplasty and stenting?
Severe stenosis at the proximal, for example, like proximal obstruction of left coronary artery.
What do you consider as proximal?
Proximal of the coronary artery, like proximal part of the left coronary artery.
What's proximal?
I'm not sure. Proximal.
Can you see my screen now?
Yeah. Can.
Okay. You see the triple vessel disease here. So the patient is actually having what? This is what? LMS is what? Left main stem. Okay. Left main stem. You know the coronary artery anatomy? From left main stem, it divides into LAD, which is left ascending. Left anterior descending artery as well as left circumflex. Then you have right coronary artery. Left main is very important. Okay, if you got left main thrombosis, the whole left heart's gone. You can just die suddenly, go acute heart failure, or you can even get severe mitral regurgitation because the mitral valve undergone ischemia. All the papillary muscle, they can get acute mitral regurgitation. So of course arrhythmia also is possible, so the patient can die suddenly. That's why indication for surgery are triple vessel disease as well as left main stem disease. So she got all these both. Okay, she got LMS disease, which is stenosis about 90%, which is very high risk of dying suddenly, as well as she also got triple vessel disease. Other than the left main stem is involved, RCA, right coronary artery also involved, circumflex also involved, as well as LAD also involved. So in fact she got all the vessels lah. Okay, so that's why she's actually planned for CAPG, but patient faulted lah, AOR discharge. Okay. Now, okay. What I want to ask you. So we discussed about. So based on the symptom, do you think this is unstable angina, or this is acute myocardial infarction, or this is stable angina? Which one?
I think it is unstable angina.
Unstable angina. Why you say unstable, not stable angina?
Because she has having durations of less than 5 minutes, within 5 minutes.
See how you tell unstable and stable angina? What's the difference? How do you differentiate stable and unstable angina?
By doing cardiac biomarker.
No, that cannot tell.
Is it the duration?
No.
Or stable angina is usually aggravated by doing physical activity.
Yeah, stable angina. When we say stable angina, means every time the patient do exercise, the patient get chest pain, or even walking. Depends how serious it is. Okay, unstable angina is chest pain when the patient arrests or very minimal exertion, which is very unusual. Let's say patient usually can do exercise, but suddenly on that day the patient just walk 100 meters and patient get chest pain. So that is unusual. Okay. So usually patient who has stable angina, they have. Okay, what's the difference between pathogenesis of stable angina and unstable angina?
Stable
What are the
angina.
differences in terms of pathogenesis?
Stable angina means stable plaque.
Stable plaque, and then unstable angina,
And the plaques already ruptured.
and then there is
Thrombosis.
So is there any thrombosis in the stable angina?
I'm not sure.
The answer is no.
No.
Okay, so in stable angina, there is no plug rupture. There is no thrombosis. So that's why the patient get chest pain after exertion is because when you do exertion, your heart pumping very fast, as well as more forcefully. So they require more oxygen. So when the patient have blockage, usually very critical blockage, more than 70%. Okay, like in this patient probably having stable angina as well. Do you ask the patient when the patient walk, would the patient feel chest pain or not?
Yes, she said when she went to the toilet, the pain developed.
Yes. So there is stable angina. So there is no plug rupture at that time. It's just because of critical thrombosis. Critical stenosis because of atheroma. Okay. But in unstable angina, there is a plug rupture. There is a thrombus set in. There is a reason why if you diagnose the patient to be stable angina, you can send the patient back home. You do not need to admit the patient because there is nothing that you want to give which you cannot give as outpatient. So of course you are going to give aspirin, the usual drug, beta blocker, calcium channel blocker, probably to slow down the heart rate, so that to reduce the cardiac contractility, so that the patient will not get chest pain. But eventually you need to do angiogram, angioplasty, or stenting, so that you can revascularize the artery. Okay, so but you do not need to admit the patient. But in the patient who is unstable angina, as well as acute myocardial infarction, unstable angina, there is a plug rupture, there is a thrombus, but the thrombus is not occluding the heart, the coronary artery completely. But in AMI, it occludes completely, so there is no blood vessel flow at all. So that's why the heart undergone ischemia. Okay, infarction, undergone infarction. So that's why this is emergency. You need to thrombolize the clot. Okay, but in unstable angina, there is a clot, but the clot may not occlude completely, or at least there is a collateral to supply the muscle. The muscle is not infarcting. Okay, so that is why you still got time. So you can just give anticoagulant. The anticoagulant doesn't lyse the clot. Anticoagulant just prevent propagation of the clot. Understand? This different. You give thrombolytic agent, it will thrombolize the clot. But if we are giving anticoagulant, it just prevent propagation of the clot. So it prevents the clot from growing bigger and bigger. Understand? Okay? Now the question is, why don't we give thrombolytic agent in unstable angina? Why we just want to give heparin? Why we don't want to give thrombolytic agent? That come risk and benefit. Okay, and from the clinical trial, we should not thrombolize a patient when the patient just got unstable angina, because if you give thrombolytic agent, there's higher risk of bleeding as compared to anticoagulant, and it's not really so critical yet. You need to give thrombolytic agent. You can actually just give anticoagulant. You know your body actually have thrombolytic agent. What is the thrombolytic agent in your body? What's the name of the agent? Where you learn your physiology then?
Is it plasminogen activate?
Yes, plasminogen. So in your body there's a plasminogen. When the plasminogen exposed to the clot, it will convert into plasmin. The plasmin will lyse the clot. Okay, so that is the reason why you do not need to give thrombolytic agent in the patient with unstable angina. What you need to give is to give aspirin, Previx, give anticoagulant. All this will stop the clot from propagating. So your body will have plasminogen, which will convert into plasmin and lyse the clot. Okay, because if you of course you can give, then the patient may end up with bleeding. I'm not sure whether you have seen patient, we treat patients with thrombolytic agent, and the patient may bleed inside the brain and die. Okay, or bleed into the gut, and patient also can die. You know, but in the emergency situation, if you don't give, in an acute myocardial infarction, the heart muscle will die. So you had to weigh the risk and benefit of the treatment. You get what I mean? Okay, fine. So that is about, you need to know what is unstable angina, what is stable angina, what is acute myocardial infarction. Okay, then of course your unstable angina, you do CHOP-T and all this is actually to risk stratify the unstable angina. If the CHOP-T or CHOP-I is positive, it's higher risk as compared to if it's negative. Okay, this means that there's still some ischemia. Okay, when the CHOP-T and CHOP-I is positive, there's more ischemia as compared to those patients who have negative CHOP-T and CHOP-I. Okay, fine. So examination, anything positive? Just tell me what is positive. Any sign that which is positive?
Only she is overweight.
Okay. The heart, there's no heart failure.
No heart failure.
So
No,
what are the
SIS.
symptoms or what are the signs of heart failure? Can you tell me?
Abdominal. This place affects sleep,
Okay. What else?
and then edema, pedal edema, shortness of breath,
The edema, bilateral. Okay, fine. What else?
shortness of breath, hepatomegaly,
Hepatomegaly. Yeah. What else?
distended neck vein, jugular neck vein. And then
pulmonary edema,
How many edema? So what are the signs?
Fine capitation.
palpitation,
Fine
High
capitation.
cavitation over the
palpitation,
By basal.
basal. Okay, fine. What else? What
heart
else?
rate, heart rate,
If the
tachycardia,
patient got murmur, in patient with heart failure, we murmur. What are the common murmur that you hear?
pansystolic murmur
Over?
over the mitral box.
What is the cause of the pansystolic murmur?
Could be due to mitral leakage, tricuspid leakage.
Huh?
Could be due to mitral leakage.
Could be due to mitral leakage. Yes. Due to why there's a mitral leakage? Why there's a mitral leakage?
Usually due to dilated cardiomyopathy.
Correct. Because of dilated cardiomyopathy, and then the mitral ring is dilated, so the valve is not abnormal. That's why the valve cannot close properly. Okay, how about the heart rate? In the patient with heart failure, what type of pulse that you expect to find? Or it could be abnormal. What type of pulse? Pulses what?
Tachycardia with narrow pulse pressure.
No, not really. Narrow pulse pressure is seen in what? Aortic stenosis, mitral stenosis. You see the narrow pulse pressure. Wide pulse pressure you see in aortic regurgitation. But what type of pulse that you see in heart failure? I'm sure it's in Nicholas Telly. You read about Nicholas Telly, there's an abnormal pulse. Okay? And narrow pulse pressure, what's the cause? Wide pulse pressure, what's the cause? You know? Low pulse volume, what is the cause? High pulse volume or bounding pulse, what is the causes? What are the causes? Pulses alternate. Have you heard about pulses alternate?
Yes.
So what is the cause of pulses alternate?
It is caused by alteration in cardiac output. So it characterized by alternating strong and weak pulses.
Yeah, what is the cause?
Usually due to left ventricular hypertrophy.
Sure. Pulses alternate. Let me Google and see. To me, it's pulse. Not very easy. I can Google pulses alternate. causes left heart failure? Okay, so I'm correct. Left heart failure. Let's see, got any other cause of pulses alternate. Or it can be seen, you may be right, hypertrophic cardiomyopathy also can see. Okay, congestive cardiomyopathy also can see. Okay, fine. And also common atrial fibrillation. You know, a lot of patients with heart failure have atrial fibrillations. So means they have irregular pulse. Okay, and then sometimes they can get ascites, right pleural effusion as well. Raised JVP, I'm not sure whether you mentioned just now. In a patient with congestive cardiac failure, sometimes they get right heart failure as well. The tricuspid regurg, you may get a pansystolic murmur, either both mitral and tricuspid regurg. And tricuspid regurg, you may get pulsatile liver as well. Okay, now, so what are you going to do? How do you want to investigate this patient?
So, in order to investigate this patient, I would like to do on the
Maybe I
bedside.
can ask your friend this question, okay? Zahari.
Yes, sir.
Yeah, after you get the history, yeah, possible unstable angina, less likely to be AMI because there's no sweating, vomiting. Okay. So what test do you want to do for this patient?
For this patient, I still would like to do ECG because patient could present with atypical.
Okay. Do you have an ECG of this patient?
No.
No. I also cannot find the ECG from the hypersaccade because I think they haven't downloaded the ECG yet. So it's probably still in hard copy. Okay, but anyway, it's written there, ECG at ED show ST depression over V3 to V6, 1 and AVL. So what do you think about this ECG?
V3 to V6. V3 to V6.
So where is the ischemia?
V3 to V6, either septum and lateral. Septum and lateral.
Lateral wall. Okay. Yeah. Septum is usually about 3-4 lah. 5-6 is lateral wall. So septum and lateral wall. So means where is the blockage based on this?
Left side. Left side of the coronary artery.
Yeah, left is LAD lah. Left
LAD,
what's that called? LAD stand for. Just now I just mentioned to you.
Ascending.
Left ascending.
Left ascending.
AD. I also forgot what it stands for. That's what I just mentioned not long ago. Left anterior descending. Anterior descending. Okay, fine. That's what show there. And then, okay, what other tests you want to do now? Other than ECG. So let's say you do ECG, you show ST depression V3 to V5. V3 to V6. So what you want to do next?
I need to order a cardiac marker.
What cardiac marker you want to do?
The troponin, cardiac troponin and CKMB.
Okay, fine. The CKMB is 20. CK is 60.
I forgot the normal range.
Normal range. You forgot the normal range. I share with you. Anyway, look normal lah. Okay, no need to share lah. Yeah. So it look normal. Okay, so are you going to do only one set or are you going to do many sets? Let's say you do TROP-T at 1 hour of presentation is negative. So what are you going to do? you going to repeat?
Yes, because it takes about 72 hours after the onset, if I'm not mistaken.
You got trop T, trop I. 72 hours, so long. Then what's the point of doing trop T and trop I?
3
How
to 4
many hours
hours.
will be positive?
First detection is 3 to 4 hours.
Okay, 24 hours? Cannot be lah. So long. Not in my dictionary. Unless you're talking about CK or you're talking about trop T.
Troponin.
Troponin, no, 6 hours. Okay, so if the patient present with chest pain less than 6 hours, it still can be false negative. Okay, so you need to repeat another one. So let's say, for example, if you are A&E MO on call, you know, you do trop T negative, you still cannot say, oh, this patient got no unstable angina. I presume with the ECG is good enough. Typical chest pain ECG is good enough. You do not need to bother about trop T. Let the cardiology handle the trop T and trop I, because it's just, as I told you just now, it's a prognostic picture. Those people with unstable angina, trop T positive as opposed to trop T negative, they have higher risk of myocardial infarction as well as death, okay, in the next 30 or 60 days. Okay, so but if you are A&E MO, sometimes what happens, patient come with chest pain, query not so typical, ECG, when by the time patient come in negative. So you see, when the ECG is negative, you always ask the patient, are you having chest pain when the ECG is done? If the patient have chest pain, ECG is totally normal, what you can do is repeat the ECG a few times. After 5 minutes, repeat again. Patient still having chest pain, ECG persistently normal, something wrong somewhere lah. Most of the time, this chest pain is not angina. Okay, so what you can do next time when you are houseman on call or MO in the A&E, that's what you do, serial ECG. But if the patient come to you, say chest pain at home, by the time reach A&E, tell you no more chest pain, you do ECG normal. You still have to think about this is likely to be unstable angina, especially when the trop T and trop I turn out to be positive. Okay, but you must make sure that your trop T and trop I don't do too early. You know, you should do after 6 hours. Okay, if the patient just came 3 hours ago having a chest pain, actually in fact no point to do lah. It's too early, you know, to detect trop T and trop I positive. You better wait until 6 hours, then only you do. Okay, and so fine. This is any other test that you want to do?
Probably we can do a bedside echo.
Okay, fine. You can do an echo. What you want to look for?
To look for, is there any regional wall to check for the any regional wall abnormality.
Okay, hypokinesia and akinesia of the wall. Yes. So
And
that would
then,
confirm that, like in this case, you look at the septum and lateral wall. If it's hypokinesia or akinesia, you know that this patient have. It's unlikely to be akinesia, right? Based on the ECG finding. Akinesia means totally no movement. Okay, so it means it's myocardial infarction. Then you will expect the ECG to be ST elevation or Q wave or E block. Okay, or it could be, of course, OMI. This patient could have unstable angina on top of OMI. Also, it's still possible. You see. Okay, fine. What else do you look for on the echo?
the ejection fraction and the
Yeah,
size symmetrical, either is there any hypertrophy, any formation of thrombus.
Yes, especially if the patient LV ejection fraction is poor, especially if the EF is only less than 20%. Sometimes they can have mural thrombus, so you want to see any mural thrombus. Okay, if the patient with AF, of course, you want to see atrium thrombus in the atrium or left atrium appendix. This is common site of thrombus. Any other tests that you want to do?
Maybe we can order BN. No, I think it's not appropriate to order BNP. The other would be the underlying, to investigate the underlying risk factor, like the accumulators.
Alright, like what we mentioned just now, diabetes, you want to see how good is the diabetic control. The patient in stress condition, the sugar can be high. Okay, he's having chest pain, you increase in catecholamine, increase in cortisol level. This is physiological, so that's why the sugar is high. So you do a HbA1c to see how good is the diabetic control. Okay, fine. Any other tests? CT, no. What other tests you want to do?
Maybe you should send to for blood count.
What you want to check a blood count?
Any increase in platelet level that reduce the thrombosis.
Okay, fine. Very rare of course you can do, yes. Whether the patient have essential thrombocytosis, a cause of thrombosis. What else? Of course, you can get polycythemia luba vera, also is a cause of thrombosis. What else?
Chest X-ray. Chest X-ray for any sign of cardiomegaly.
Okay, fine. But you already do. If you order echo, then not necessary lah. But of course, you want to see whether got heart failure or not, outward diversion, or evidence of pulmonary edema, backwind sign, pleural effusion, curly D line. Yes, you can do a chest X-ray. What else?
Protein profile, electrolyte imbalance.
Yeah, check electrolyte imbalance.
Always.
This patient diabetes, you don't want to look for complication of diabetes.
Complication of diabetes.
Yeah, so that's why you see in exam, you need to say, okay, I would like to investigate the acute problem, which is possible unstable angina, and look at complication of the current problem. And don't forget about the background disease that you need to monitor the diabetes as well as look for complication of diabetes. This is the best time where the patient is in the ward to look for any nephropathy. You can refer eye if the patient has never seen ophthalmologist before. Then you refer ophthalmologist to look for any retinopathy, peripheral neuropathy. Of course, you can examine yourself. Okay, and then you can also look for nephropathy. And how do you want to check for any nephropathy early, especially? What's the earlier sign of nephropathy?
Proteinuria.
Yeah, proteinuria. So what do you do? Just urine distich, is it good enough? Or UFME? What's the best?
24 hours urine protein.
Yeah, you can do 24-hour urine protein, or you can look for microalbuminuria. There's a special dipstick that actually can detect microalbuminuria. Do you know what's the definition of microalbuminuria? How much the quantity of albumin before we say it's microalbuminuria? I'm sure you know microalbumin doesn't mean the albumin is very small size. It's just a quantity of the actually, normal person, you still leak out albumin in the urine, but it usually less than 20. Okay, so if it's microalbumin, it's between 20 to 200. Okay, anything else? Any other test that you want to do? Okay, principle of management we actually have gone through lah. If the patient had unstable angina on admission, what will you do? Just summarize everything. Maybe I can ask Isha. What would be the principle of management for these patients?
So for the principal management, if presented chest pain, so we do the resuscitation first, secure for the airway, oxygen, and also the breathing.
Patient is stable lah, okay, fine lah, no need airway. Okay, come on lah, in exam, let's say I will tell you vital sign is stable, everything. Patient can give you history, no need talk about ABC anymore lah.
Okay, So for the immediate management, for the urgent medications, we can give anti-dual platelet. So we give aspirin 300 milligram and also clopidogrel. So so that's first, and then second.
What is the difference between aspirin and clopidogrel?
Aspirin is an anti-platelet for COX inhibitor. It acts on the COX inhibitor, while clopidogrel,
so you don't know. You're giving the drug without knowing what is the
both is anti-platelet.
what's the mechanism of action? Add on what? You also an anti-platelet, but it's an ADP receptor antagonist. Okay. Fine.
So after give anti-dual antiplatelet, we can give sublingual GTN for every 5 minutes. If the pain is persistent, we can consider to give IV nitrates. And we can also may consider to give anticoagulation therapy. Anticoag, such as fondaparinux
anticoagulant.
Anticoagulant.
Not anticoag. Anticoagulant.
Anticoagulant.
Okay.
Okay. Such as fondaparinux or low molecular weight heparin. And what else?
Any other drug other than low molecular weight heparin that you know?
Unfractionated heparin.
Okay, fine. What else?
Fondaparinux.
What is fondaparinux? You better know all this. I'm going to ask you this in exam, okay?
Okay.
When is your exam?
In 2 weeks.
Oh, in 2 weeks. Very good. You still don't know yet. What is fondaparinux? Is what? Is it a heparin?
It's a synthetic heparin.
Huh?
Is it synthetic heparin?
No, it's not synthetic heparin. It's anti what?
Anti-factor 10.
Yeah, 10A.
10A, yeah, anti-factor A.
Okay. So, find any other drugs that you want to give for this patient? He's got triple vessel disease.
So triple vessels.
And then your friend say that she also got stable angina on top of the unstable angina. So as I told you early on, so I say I all discussed already. It's just now I want you to summarize the whole thing. So you want to slow down the heart rate, you want to slow down the cardiac contractility. So what can you give?
We can give beta blocker to control the heart rate.
Beta blocker, yes, but she read on lah beta blocker. So you may want to increase the dose of beta blocker. She already on bisoprolol, okay? But 5 milligram is still not maximum dose yet, so you can increase the dose. Okay, what else? Let's say you maximize the beta blocker, patient is still having ischemia, still having stable angina, and not keen for angioplasty. You know, what else can you do?
Maybe you can change to calcium channel blocker.
Yeah, you can add in calcium channel blocker. Okay, what else? In stable angina, what else can you do? Basically, you can also, you see, just now I told you want to cut down the demand, right? By decreasing the cardiac contractility and heart rate. Okay, or you can increase the supply, right? So how you want to increase the supply?
GTN bagi dah sekejap. We can
No, GTN is acute. I'm talking about in the patient with stable angina. So you want to give vasodilator, right?
Okay, yes.
Yeah, vasodilator. Yeah, nitrate. You can give nitrate regular dose to the patient. Okay, there's a slow release nitrate now we can give. Okay, what other drugs that you give?
Maybe we can give ACE inhibitors or ARB.
Yes, ACE inhibitor. Okay, what else?
That, if this patient have a high lipid profile, you can give statin.
I'm sure all the patients with ischemic heart disease
okay.
have high lipid profile.
So we give
You know what's the
statin.
aim of LDL that you want to bring down to? You know lah. This one you don't know, so I don't mind. I don't penalize you.
No, I don't know.
You want the LDL to be as low as 1.6.
1.6.
You know, I don't think any human being got LDL 1.6 before treatment. Before treatment, I say. Okay? So every patient needs statin. Everybody needs statin. You don't believe me, you go and check all your class. All your classmates, anybody got LDL less than 1.6, you can come and claim KFC from me. I'll blunder you for the whole year. Okay?
Okay.
2 point something, yes, we see quite often, but 1 point something is very unlikely. Okay. Anything else? Any other drugs can you give?
I think that's all.
Yeah, that's what you need to know lah. Okay, there are a few others that we give as well, but I don't think is really important. Okay. Okay, fine. Okay, we can move to the next case. Any other question about this? So basically, you need to know acute myocardial infarction, stable angina, unstable angina. We have discussed about pathogenesis of each of the condition. I also told you about pathogenesis in related to treatment, as well as and you know that you need to know risk factor of ischemic heart disease, and you of course have to deal with the risk factors. Yeah, make sure the patient risk factors are well controlled. But I know that this is a difficult patient. Default here, default there, not taking medicine properly, you know. But she has been having diabetes and hypertension for so many years. So now she got all these complications. Okay. She's high risk of sudden death. So if you see this outpatient, you're going to tell left main stem disease. Usually when the patient have left main stem infarction, patient will present with sudden death. Okay, or they can go into acute heart failure, and you know, a lot of time prognosis is very poor. That's the reason why indication of bypass surgery. We did talk about bypass surgery, triple vessel disease, and left main stem disease. Okay, fine. Who is going to present the next case?
Me, Prof.
Yeah, okay, we can start.
Okay, actually I am still in quarantine, so I still in quarantine. So my patient is already I clocked during last Saturday. I think he already discharged. Okay, my
Can I
patient.
just give me the patient RN? Do you have patient RN?
I check. 107
107
430
430.
7.
Okay, fine, can carry on.
107 4307. Okay, my patient, Ajit Zambri, 62-year-old gentleman, already retired, with history of multiple episodes of pneumonia previously, in previous year, presented with coughing out blood for 2 days. Patient, prior to the admission, he actually had been coughing for several days. Patient forgot how many days it was. The cough was productive in nature. It was only minimal amount, around a spoonful of white sputum. There is no full smelling. He coughed more than 5 times per day. As the cough worsened for after days, he noticed the sputum stained with blood. Initially, it was pale red in color, which he decided to neglect it first. However, the coughing out blood was persistent and got worsened until the day of admission. During the day of admission, after his prayer, he expectorated frank blood. It was bright red in color and it was about a spoonful in amount. There is no blood clot. So due to that incident, he decided to seek for treatment. He denied any anemic symptoms like palpitation, dizziness, looking pale, or syncopal attack. Otherwise, there is no any history of fever, shortness of breath, chest pain, or pleural chest pain. There is no any symptoms like cough pain. He denied any history of constitutional symptoms, night sweat, history of sick contact with TB patients, or any person with similar presentation, no recent trauma to the chest, or no any family history of malignancy. There was no symptoms to suggest coagulopathy like hematemesis, epistaxis, rectal bleeding, or hematuria. He denied taking anticoagulant medication. Otherwise, there is no other respiratory symptoms like runny nose or noisy breathing. He was a social smoker but already stopped last 2 years. He smoked very occasionally, depending if there is any special event or upon meeting friends. He smoked 3 to 4 sticks per day at most. There is no any high risk behavior like sexual promiscuity or taking alcohol. So at the emergency department, the vital sign revealed hypertension. He was febrile. Blood investigation were done and chest X-ray also taken. He was given antibiotic and then was admitted for further investigation of the cause and monitoring. So that's all my HOPI. Basically,
you say he's got recurrent pneumonia.
Yes.
How recurrent is recurrent?
Patient could not remember exactly, but the first presentation is during 1979. That is the first presentation, and then last 3 years.
So do you think it's related to current problem? 1979. You can ignore it. Okay, fine. Doesn't matter. What's the second one or third one?
Patient claimed that he was admitted due to respiratory infection, but patient could not recall it.
Years? Roughly which year?
Patient said that last 3 years, at least.
How many times? One.
Patient said 2 times, but he cannot recall. So I cannot obtain the specific history about the pneumonia.
I see. Okay, fine. So you shouldn't present your history like this patient having recurrent pneumonia. When you say recurrent pneumonia, I was thinking about for the last 6 months to 1 year, this patient have multiple courses of antibiotics. Okay, so the one that donkey years ago, 30 years ago is probably not related to current problem. If it's related, it will be disease like bronchitis, quite harmless sort of infections. Okay, so the important thing is you got patients that tell you got a few infections going on. You need to know exact date or exact how long ago, then how the patient was treated. Any X-ray done. So what we worry is if the patient had persistent infection in the same loop of the lung. Okay, so what you worry if the patient had persistent infection in the same loop?
Because can it complicate with interstitial lung disease or bronchitis? Maybe we worry of complication like bronchitis or interstitial lung disease, fibrosis.
No, I mean if the patient had recurrent pneumonia and then involve one lobe, let's say for example X-ray showed lobar consolidation, let's say right middle lobe consolidation, and this patient tell you for the past 3 months or 6 months the patient have fever, cough, took antibiotic, resolve, then happen again, so maybe 3 times the patient need to take antibiotics, and you do a chest X-ray, it show right middle lobe consolidation. What are you worried? So it's unusual, right? And then even you got pneumonia, it shouldn't be on the same lobe all the time. So if it's on the same lobe all the time, what are you worried?
Is it cystic fibrosis or?
No, cystic fibrosis won't be only one lobe. And cystic fibrosis won't cause consolidation. It causes bronchiectasis. Anybody know?
I'm not sure.
Abscess.
Abscess, you straight away see there's a cavity. It won't be consolidation in the lung. Cavity with every level. Of course, you can get abscess that can get recurrent infection if it's not treated properly.
Is it has something to do with like middle lobe syndrome? But I've not read about that.
Middle lobe syndrome is bronchiectasis. Patient with bronchiectasis over the middle lobe and lingular lobe. So we call middle lobe syndrome. That one is not consolidation. So the one you got to make sure there is no obstruction. So a lot of time it may be because there's an obstruction or partial obstruction of the bronchus. Okay, in the old people who are smoker, you got to think about carcinoma of the lung. Of course, in the young patient, you got to think about benign tumor. Okay. We just have one case. This lady is going to get admitted on the 28th in Susmet. This lady actually 3 years ago first presented with pneumonia, admitted to the ward, and the sister-in-law is a radiologist, so do a HRCT for the patient. And the patient had bronchiectasis over the middle lobe and lower lobes on the right side. So this patient then have a few courses of antibiotic in between. So this year she had another episode infection. So she come and see us. Because the first time was not referred to us, you know. And so we order a CT scan again, and we find actually there's a mass obstructing the middle lobe and actually extending all the way to the right main bronchus. So we did a bronchoscopy and biopsy. It turned out to be carcinoid tumor. Okay, actually looking back 3 years ago, actually the HRCT already showed there's a mass inside the airway, but it was missed. Okay, and these are the patients that present with recurrent infection. So luckily it's benign lah. Okay, because why? Carcinoid is a benign tumor, but they can turn malignant. So carcinoid can become atypical carcinoid, mean there's some malignant change already, and then they go malignant carcinoid, which they can metastasize. So on the 28th, I'm going to do rigid bronchoscope and coil out the whole tumor. She's going to be a good case. You can watch for her when she comes. Okay, she got clubbing and she got crepitation in the lung. I think some of you have seen her with me last Friday. Your group, I don't know who. Okay, so just to let you know, so if you get a patient with recurrent pneumonia, always exclude obstruction. So I have patient who came in with persistent consolidation, either middle lobe or lower lobe, and we go in and scope, and there's a foreign body granuloma. So there's a fishbone. Actually, this patient would choke in the fishbone many years ago. So it will grow granuloma, and because it causes partial obstruction. So when there's a partial obstruction, imagine the mucus. You know, your lung produce a lot of mucus, but the mucus cannot be moved to the proximal airway. You know, this is a normal defense mechanism, you know, right?
Yeah.
So the cells, there's a lot of Goblet cells in your airway, and they will produce mucus. That's why you need a ciliated epithelium. So to move the mucus to the trachea, and then after that you will swallow. Then it go to the stomach, and then the acid in the stomach will kill the bacteria. So that's why you don't get recurrent infection. But if you are a smoker, smoking actually impair your ciliary function. That's why as a smoker, you're at risk of getting infection. Any infection, whether it's TB, COVID, or bacterial infection. So tell all the smokers don't smoke. Okay, because it impact your ciliary function. Of course, you get patients with cystic fibrosis or carcinoid syndrome, you know, so their cilia is not normal, or the mucus that produce is thicker, so it's difficult to clear. So that's why they get recurrent infection and they get bronchiectasis. So this is the pathogenesis of the disease. Okay, I hope you know. So we will ask you this in exam. If I give you a bronchiectasis patient, I'll ask you what are the causes. Then you say cardiac syndrome or cystic fibrosis. I'm going to ask you what is the pathogenesis they get bronchiectasis. Okay, so you better know what's immortal cilia syndrome or cardiac syndrome, as well as cystic fibrosis. Okay, so fine. This patient on top of pneumonia also has hemoptysis. It's not I would say it's common also. Sometimes pneumonia also can get hemoptysis, but bronchiectasis definitely can cause hemoptysis. TB is something that you got to think of. But I can't find your patient in Ibasake. Are you giving me the correct registration number?
I repeat. 107.
Yeah.
4307.
Oh, there's another 7. Okay, they don't allow me to see because I never see this patient before. Sometimes they don't allow. Sometimes they allow. I also don't know. Because if it's inpatient, I can see. But if it's outpatient, I cannot see. Mean the patient discharged, I cannot see. Okay, doesn't matter. I thought that if I can show you the CT scan or chest X-ray or whatever. Now,
I did take the chest X-ray from. I asked my friend yesterday to take the chest X-ray.
Okay, fine. So you want to? Okay, sure. What? Any other history that you want to tell, or anybody want to ask anything? Otherwise, we can have a look at the chest X-ray of the patient.
Patient didn't have any underlying medical illness except for hypertension, but just diagnosed on admission.
Okay. Fine. So you want to show her the chest X-ray?
Can you all see the slide?
Yes.
This is his chest X-ray. He never. I think he didn't do any CT.
Okay. Before you say anything, I want your friend. Can you enlarge a bit?
Enlarge. Okay.
Yeah. Okay. No. I want to see. Yeah. Okay. You don't want people to see the apex of the lung.
Okay.
Move out a bit. Okay. Move out a bit. At least you see the whole X-ray. Okay. Good. That would be nice. Okay. Why don't you ask your friend? You choose which one that you want them to interpret.
Can we call AJ?
Can you interpret this chest X-ray? Since you don't know what's the diagnosis, so you can help to interpret.
Okay. So this is the chest X-ray of this patient. I'm sorry, I cannot see properly. Okay.
No, it's good enough. If
Okay.
you want, you can.
So there is a opacity at the left lower lobe of the lung, and there are loss of prostrophin angle also.
Anything else?
Reticular
Why don't you okay, the apex of the lung and the upper part of the lung look quite normal huh? Why don't you enlarge, just focus on the second half, like this, only second half of the lung, bigger, enlarge a bit bigger, yes, no, okay, like this, okay, fine. Now take your arrow again away, yes, now it's clearer now. So what do you see? You want
reticular
to
change.
take opacity, or is there anything else that a better description?
Opacity.
You still want to use opacity?
No.
Opacity is a very non-specific term. I don't like
Reticular changes. Is it?
reticular changes. Where is the reticular changes?
At the left lower lobe.
Left lower lobe.
Yeah.
The pointer you are pointing or your friend is pointing?
Haika is pointing.
Yeah. Okay. Anybody can give a better description except Zari. I'm sure Zari know the. Is Zahari your name or your father's name?
Father's name.
Oh, sorry.
Okay.
Haika.
Okay. I don't know. I also don't know the finding of the patient.
Oh, you also don't know the findings. Okay.
Because I'm quarantine.
Anybody thinks that is better, or you got a better description? Yeah. Everybody know that there's a left lower zone is not normal, or is you can call it lower lobe, but in lingular lobe may be involved as well. Okay, but I will not call this as opacity. Okay, in fact I can see anybody want to or Zar or Haika, what do you see?
I'm not sure whether this is the tram line.
Yeah, there's a tram line. Okay, show them where is the tram line. The one they very clear one. Don't show proximal airway, because proximal airway is very difficult to tell. Sometimes it may be just normal. Okay, here, yes, this one. No, just on the pointer. This one. No, a bit out. Yes, this is a tram line. No, just not. Oh, yo, why so leaching one? Your mom. This one. You see this? There's one line on top. There's one line between below. So the one below.
Okay.
Correct. This one is below. So can you follow all the way to the distal part? Just follow
like this.
No, it's not that. That is the ribs. The tram line is supposed to be, it's the airway which is dilated. Okay, so inside it should be clear.
Is it like
yes, this one. Okay, follow. Yes, correct. Then the another one, the bottom one. Follow. Correct. So this is the typical tram line. Okay. In fact, if you follow, it go out. It can go out some more. Out some more. Yes. Out. Yes. Correct. Correct. Okay. So, and then on top of that, what else do you see beside the tram line? What do you see? How do you describe this rounded thing?
I try to find a ring shadow, but I cannot visualize it.
You want to find what? What shadow?
Ring shadow.
Correct. Cystic changes, or you can say ring-like lesion. You see, this cyst, multiple cysts there, around that. Yes. One, just below this, Okay, yeah, correct. Another one, and in between also got one more. In between.
This one.
Yes, this one. Correct. Okay, and then also below the tram line, one more below the tram line, just below it. This one a bit weak. On top is a clearer. Correct. This one. Okay. Another tram line. Can you see another tram line on the medial side? Medial side. No. Okay. Don't move so fast. I'll tell you which one. Go a bit left. A bit medial. Medial. Okay. See this line. Okay. Follow this line down. Yeah, you can follow out also can. You can follow out. Okay. Yeah. So unless you want me to control. But we always face technical problem lah. You want me to control? Can you allow me to control? So okay, I will tell you if there's a tram line, there's a cystic changes. What is your diagnosis?
My provisional diagnosis would be a bronchiectasis.
Can you see my pointer? No, I think you are still controlling.
Yeah. I can't see.
Yeah, you are still controlling.
Or can we give it to you, this image?
Yeah. Oh, you mean you share in the group, or in the you ask your friend to WhatsApp me. But actually, they will allow me to share to use the pointer one. doesn't matter lah. I think it's fine. Actually, you can see on the media lower, just behind the heart, there's another tram line. Okay, so basically on the X-ray, there's a tram line as well as cystic changes over the left lower lobe, and linguinal lobe may be involved as well. What you try to do? Can you see my pointer? Cannot. Still cannot, right? Okay, doesn't matter. I mean, don't waste time on this. So this patient most likely have bronchiectasis. Okay. What are the investigation that you want to do, which is really can appreciate better? And also at the same time, as I say, you want to exclude intraluminal lesions. Is to do a
HRCT.
HRCT. So I think this patient should have HRCT. Did they order HRCT for this patient?
They plan for outpatient.
Okay, fine. As long as they do it, it's fine. Okay, so there are two reasons. One is confirmed bronchiectasis. You can see how extensive is the bronchiectasis. Also at the same time to exclude intraluminal lesions. Okay, even though sometimes what I do, if let's say I look at the HRCT, but sometimes what you see on the X-ray, you see only left lower lobe and the linguinal lobe. But when you look at the HRCT, you see diffuse everywhere. Right side also got, but probably in less severe intensity. So then it's fine. But if you only purely see just one lobe is involved or two lobes, I will actually do a bronchoscopy to exclude intraluminal obstruction. I just actually share with you that case. That this patient is going to get admitted. Her name is Mastura. You can wait for her to come on the 28th. We are doing the retreat score on 28th, so she will be admitted on 27th. So on the 27th afternoon, if you want, you can go and see her. She lah, so it's going to be IM2. Okay? So in summary, this patient likely to have bronchiectasis. This is very easy to diagnose. Your chest X-ray is also very typical already. But what you need to do is let's see whether I can find one of my bronchiectasis. Maybe you had never seen this. It's my favorite exam questions. But I show you already, I mean I cannot come out with exam already. Okay, sometimes you can get it's not easy to search. Because I got so many pictures here, and you kena cari one by one. No, I think it's going to be waste of time. You myself just okay, I just Google bronchiectasis. So sometimes they appear like small abscesses, you know, because they can have filled with mucus, and then sometimes there's a finger in glove appearance as well. So when you have bronchiectasis, let's see whether we can have air fluid level. And sometimes you can get air fluid level as well in the airway. So you can see these cystic changes with air fluid level, you know. Easy to find. Here got one. Let me share. You allow me to share screen. This is my favorite pictures. I always, yeah. Can you see this picture?
Yes,
see,
Prof.
Yes.
But this is not from me lah. This one is from internet, from Google. Okay, and you can see these are cystic ring, you know. So I actually Google bronchiectasis with air fluid level. So why is because if you when it's infected, you know, so there are multiple air fluid level. Okay, so some of the bronchiectasis is very big. So this is what we call secular bronchiectasis. But I don't think you need to know lah. Okay, you can see all these cystic changes here. Also lateral view, you can see cystic changes. You see my pointer, right?
Yes.
Yes.
Yeah. So when the bronchiectatic lesion is actually infected with, usually it's pus lah, you know. So the most common organism is Pseudomonas aeruginosa, and you can see nice airfloid level here. This one also another one got airfloid level. And here, see, multiple airfloid level. So it look like abscess. So some people mistakenly this abscess, but it's actually due to bronchiectasis. Okay. Yeah. So this how the HRCT look like lah. Okay, in the patient with bronchiectatic airway, which is actually infected. You can see there's airfloid level here as well, multiple airfloid level. Okay. It's quite common, you know, bronchiectasis. Now, how do you treat bronchiectasis? As I say, here another one very nice airfloid level. Okay, sometimes you have this finger in glove. Maybe I just straight away. Finger in glove. Okay, yes, something like this. This one also can. So this one means the whole bronchi is all filled with mucus plug already. Okay, so it look like there's a lot of fingers inside the glove. Okay, this one to me is not so typical. Sometimes it's even more typical. Finger in glove, something like that. And you see they put a glove there for you to see. Yeah, here another one. Okay. Yeah.
Probably it is common to see increase in bronchiovascular marking. Other sign like increase in bronchiovascular markings.
Bronchiovascular marking? Why suddenly ask about bronchiovascular marking?
No, I just ask you, is this common in the bronchiectasis to see bronchiovascular marking is increased?
No. It's just a dilated airway lah.
This seem like tram track line.
No, actually tram line is actually dilated bronchus. Like this one, if you see on the X-ray, it will be tram line lah. Tram line. So you come out, because you know what's tram line? You hardly see tram in Malaysia lah, but overseas you always see tram running on the road. So that's why it come out with all this. So you got to say tram line on chest X-ray. Then only it come out. Okay. So it's just the two line parallel. You know it's tram line, right? Jalan Keleta Tapi lah.
Yes.
The Keleta Tapi tram. I see here. Just how we see the same thing. You see two line here.
Yes.
Parallel, which is thickened. Okay. And you try to see on the peripheral airway, because central airway, you always see bronchus also look like tram line, but that's normal bronchus. Another one here, side by side, but very small image. Sorry, excuse me. Okay, fine. So now, okay, how do you treat this patient? When this patient come to you, how do you want to treat the patient? So your diagnosis is what? Okay, how do you want to call the diagnosis?
Provisional diagnosis would be post-infectious bronchiectasis. Can it be like that?
No, you should call infective exacerbation of bronchiectasis at this moment in time. So what happened was this patient had bronchiectasis. So patient with bronchiectasis, when they may be stable, no infection. So when they come with infection, you call it infective exacerbation of bronchiectasis. Okay. Now of course you got to find out what is the cause of bronchiectasis. Okay. You can propose, like in this case, because it looks very localized, you can say to rule out intraluminal obstruction. Okay. And so as I say, you need to do HRCT for the patient. As for the bronchiectasis, what do you do? What test will you want to do? Patient will have cough with a lot of sputum, like what you say, hemoptysis as well. So what do you do?
We will do a sputum culture.
Yeah, sputum culture. The most common organism I already told you, right? Which is?
Pseudomonas
Pseudomonas
aeruginosa.
aeruginosa.
Yeah, commonly Pseudomonas aeruginosa, about 30%. The rest are the usual organisms like Klebsiella pneumonia, Staph aureus, strep as well. Okay. Next. What
For
other
the
tests you want to do?
test. We can do a TB workout because it's one of the, but this is
Unlikely
less
to be TB lah in this case because it's in the lower lobe,
application.
not upper lobe. Okay. NTM, yes. Non-tuberculous mycobacterium, yes. It can cause fibro. It can cause bronchitis, and it can be anywhere, not only upper lobe, but usually it diffuse bilateral. They won't just choose to the. But as I told you, if you do HRCT, you may find out it's actually diffuse, but predominant of the left lower lobe. Yes, if you see it's diffuse, you can send AAB direct smear, MTP culture, and you got to think about it could be NTM, non-tuberculous mycobacterium. Okay, what else? What other tests you want to do? Let's say, for example, it diffuse. You want to investigate as, it could be cardiogenic syndrome, or it could be cystic fibrosis, or congenital immunodeficiency. What test do you do? What test? Hello? I already tell you the causes when it's diffuse. Cystic fibrosis, what test do you do?
Sweat.
Sweat chloride
Yeah,
test.
sweat test. It doesn't matter how to do it, okay? I won't ask you in the exam because I also don't know how to do. Cystic fibrosis is not common here. It's common among Masale. We hardly got any cystic fibrosis. So I also don't know how to do sweat test. And nowadays you can check the chromosome straight away. I not even remember what chromosome lah. It's actually a chromosomal abnormality. Let's Google and see what chromosome. It doesn't matter lah. As long you know the basic, I think should be fine. Okay. You can check immunoglobulin level. Cystic fibrosis, chromosome 13 to 15. So it's fine lah. No need to remember. Okay. What other tests that you want to do?
So for this patient, maybe we can order full blood count because we say that it's effective exacerbation. So to check for the blood count.
Fine.
And then we can do also CRP, inflammatory markers.
Okay.
And then check for
to me lah, okay, to me lah, you can answer this in exam, no problem lah. When you're houseman or MO, no need to waste your time, ESR, CRP lah. Actually, I can tell you one thing, all these are useless tests. It just costs your lab technician to work harder, wasting the resources. Because anyway, clinically, a patient has infection, there's no point to do. You must understand that when you do CRP, of course, like your ICU patient, you want to monitor the CRP to decide when to off the antibiotic, then you do lah. But come on lah, patient with infective bronchitis, antibiotic is standard lah, 10 to 14 days. So you don't need to monitor CRP. And then in fact, if the patient hemoptysis settle, I discharge the patient already. Bronchitis patient, they will not get sepsis one. So a lot of time we admit them is just because of hemoptysis. So you worry they get massive hemoptysis. Very rare bronchitis will cause massive hemoptysis. Not a common cause. Okay, but as I say, you do not need to do ECT, ASR, CRP, wasting money. Okay? Yeah. Even full blood count also is a waste of money. If you examine no fellow, nothing. But you know, it's so routine we do lah. Full blood count, renal function, liver function. That is like almost all patients we do base so-called baseline. Just in case the patient got renal impairment without you knowing, and then you want to give antibiotics that, especially gentamicin and whatever is compromise the kidney function. So that one is still logic to give, to do. Any other tests?
I think no.
So is the patient having shortness of breath?
No, patient only has cough and hemoptysis.
Because sometimes the patient may have obstructive airway disease as well. So you may want to do spirometry, but not during acute episodes when their patient is well. When they are discharged already, you can do spirometry as outpatient, just like your HLC. Okay, but the principle of treatment of bronchitis is first find what is the colonizer. Okay, usually their airway is not going to be sterile. They're always full with bacteria, and usually there's one or two bacteria which is predominant. So if it's Pseudomonas aeruginosa, every time when they get infective exacerbation, you just give Pseudomonas and just give anti-Pseudomonas. So what are the drugs which is anti-Pseudomonas?
Usually we give ciprofloxacin.
Yeah, ciprofloxacin is the best because you got oral. In fact, if the patient is very well, you can actually just give oral. Okay, I don't know what's the reason I'm meeting this patient. I presume hemoptysis. You can give oral ciprofloxacin so that when the hemoptysis settles already, you can send the patient back. So what drug can you give for hemoptysis?
Is it to relieve the bleeding, like transaminase?
Yeah, to reduce, to stop the bleeding.
Transaminase acid.
Yeah, you can give transaminase acid to the patient. Okay, fine. And then what are the important treatment for bronchitis?
Sputum clearance, like we can give mucolytic and physio.
Do you think it's going to work very well? Not too well, okay. But what is the best to clear out the secretion? Which is cheap. But you need manpower, it's actually not cheap.
Is it rehab, chest?
Yeah, physiotherapy, chest physiotherapy. So I'm sure the patient was referred for chest physio. And the patient who have bronchitis with recurrent chest infection, you will teach the family member to do physio. And you can either do it yourself or else you ask someone else to assist you. Okay, there's some device like flutter device, capella, all this can be used. But to you, just say refer to physiotherapy department, the physiotherapist will know what to do. Okay, and then you can do daily physio. Sometimes they are so bad that they will get infection every, like 2 weeks or so. Some of my patients, like every month, they need antibiotics. So some of these patients, we ask them to do physio twice a day. Okay, twice a day. Sometimes we give cyclical antibiotics. Okay, but I don't like cyclical antibiotics based on study. There's high risk of getting multi-drug resistant organism. I rather give them antibiotics. Usually my patients who have recurrent infective exacerbation of bronchitis, I will give them antibiotic to simpan. Just keep at home. If any time when they have the sputum turn yellow, green, they will take a cough antibiotics rather than they just take blindly. So this is what I call PRN. They can take when necessary. Okay, fine. So that is about bronchitis. Anything to ask? You want to discuss one more case? We can do one more because we still quite early, 11:30 only. Maybe we can rest for 5 minutes. Okay, my buttock also pain, sitting for so long. Okay, so we rest for about 5 minutes, then we'll come back. Okay?
Okay, Prof.
Okay, Prof.
Thank you so much,
Thank you.
Prof.
Prof. Siapa nak pizza ke sini? Aku ke?
Boleh.
Aisyah, kau record kan macam ni?
Record. Nak bayar.
Wait, tak apa ke? Kes lama ni. Aku risau pula. Tak apa.
Dia dengan present
Aku boleh je present ke ejen nak? Kau nak belajar mana?
Maybe we can have a quick one.
Yes, yes.
Sure, start.
Hello? Are you going to present?
Oh yeah. Oh, ingatkan nak tunggu Prof cakap apa. Okay, Prof, I start
Yeah, sure.
Dini Arina, 23 years old Malay lady with a known case of hypokalemia, came to suspect with chief complaint of recurrent generalized limb weakness for 2 days duration. So this is actually her fourth admission with the same chief complaint, and the weakness started at the lower limb bilaterally, and it started from the distal part and progressed ascendingly to proximal part of the leg and then to the upper limbs. So it was not associated with loss of sensation, numbness, pain and muscle cramp. It involved proximal muscle more than the distal part. The weakness was exacerbated upon movement and heavy work when where she will have difficulty to stand from sitting position. So patient claimed that yesterday she did some house chores in hot weather and made her sweat a lot, and this episode precipitated the weakness symptom. So to relieve the symptom, he bought potassium chloride pill from nearby pharmacy. So the pattern of weakness is periodic during the 2 days, where one attack lasts about 30 minutes. However, the frequency and duration increased and made her claim to suspect. Fortunately, she's still able to ambulate but need to be supervised and helped by her mother for safety. Otherwise, there is no weakness elsewhere such as eye muscle, respiratory muscle and rectal muscle. There was also no symptom of slurred speech, facial asymmetry, headache, blurry vision, neck pain or back pain. So the weakness was associated with lethargy, where the patient claimed she was just lying at bed all day long and have no energy to carry out daily activity. However, there was no fever, no dizziness, no syncope or syncope, no loss of consciousness, no nausea and vomiting, diarrhea and constipation. And patient also denied any hypo or hypothyroidism symptom. So for this hypokalemia, patient was diagnosed with hypokalemia when she was 17 years old, which is 6 years ago at HTA. So during the first admission there, the chief complaint is similar, where the patient have weakness. Her last admission due to weakness is 2 years ago in Susmek. She was admitted to ward and was given intravenous potassium and her symptom relief, and she was discharged with follow-up every 3 months. However, she had defaulted her follow-up in MOBD Susmek, but she claimed have multiple attack, and the last attack was on this year March 2021, which is 7 months ago. So most of the time the symptom will be relieved by potassium chloride pill that she bought in the pharmacy. She claimed that the weakness was usually associated with increased workload, hot weather and sweating and diarrhea. Other than this, it was not affected by cold, fasting, menstruation and infections such as URTI. And she also denied other symptoms due to hypokalemia such as palpitations, syncope attack, muscle cramp or spasm, no respiratory failure, nausea, vomiting or constipation, and no hypoglycemic symptom and no dehydration symptom or tremor.
Why you ask all these things? Why?
Because patient came with hypokalemia, I want to explore more about the symptom of hypokalemia the patient have other than weakness.
So what other symptoms that the patient may have? Hypokalemia.
Palpitation.
Anything else? But you ask so many things.
Palpitation and also for respiratory failure since
in fact, a lot of times they don't get palpitation. What will be the effect of hypokalemia on the heart?
Arrhythmia.
What type of arrhythmia?
Arrhythmia.
It's not hyperkalemia, no, it's hypokalemia.
Hypokalemia.
Yes.
So cardiac arrhythmia, he can get cardiac arrhythmia, but usually on ECG, hypokalemia we will see ST depression or decreased amplitude of T wave.
T inversion.
T inversion, yes.
Okay, but that is just T inversion.
But from what I read, hypokalemia can also occur with cardiac arrhythmia or atrial fibrillation or paroxysmal.
Yeah lah, what type of cardiac arrhythmia?
Paroxysmal supraventricular tachycardia.
Is it? What that I know of.
Or ventricular fibrillation.
That is hyperkalemia. Hyperkalemia can cause VT, VF, hypokalemia, a lot of time, it will just cause cardiac arrest, asystole. Okay, doesn't matter lah. Anyway, it will affect the heart, but you're probably too late to ask about all this, you know. Of course, it can cause all these ectopics. Quite common. Any electrical imbalance can cause ectopics. Yeah. Okay, anyway, doesn't matter. What I want to ask you is, you already know this patient of hypokalemia. Tell me, what are the common causes of recurrent hypokalemia?
Recurrent usually can be due to alkalosis.
No. This sort of symptom, what's the most common cause? This is called what? What is your diagnosis?
For this patient, the diagnosis is periodic paralysis, hypokalemia periodic paralysis.
Yeah, hypokalemic periodic paralysis. Okay. Tell me, what are the common precipitating factors that they get hypokalemia? What is
Usually, although the GI, like vomiting, diarrhea, so patient can get
loss,
loss of on GI tract.
Anything else? Not due to loss. They eat something.
Diuretics.
Yeah, of course, diuretic can cause that as well. So all these are the common causes of hypokalemia lah. Vomiting, diarrhea.
And also, if patient is on insulin can also cause hypokalemia.
No. In the patient with periodic paralysis, they are not on insulin. Why should they on insulin?
Okay. So
if they got sweating a lot, they can go into attack or hypokalemia lah. Vomiting, diarrhea, or if they take diuretic, but there's no reason why they should take diuretic. Okay? But what else? If you go and have you read about hypokalemic periodic paralysis?
Yes, a bit.
What are the common precipitating factors? You Google also, I'm sure Google can tell you. Google is
eating a lot of sugar.
High carbohydrate diet.
Alright, so that's why I'm waiting for you to ask about high carbohydrate diet. They get periodic paralysis, but you never ask specific for that. Okay, that's one. The second thing is, now, what are the causes of periodic paralysis that you need to exclude? A lot of times, idiopathic, no cause can be found, but there was some condition that can cause the same symptom or the same periodic paralysis due to hypokalemia. So what are the disease that can cause that? Do you get what I mean or not? There's some condition also can cause hypokalemia periodic paralysis, but they are associated with underlying disease. So what are the underlying disease that can cause that?
One that I found is thyroid.
Correct.
Thyroidosis periodic paralysis.
Alright, one more.
And
With family history, usually they have family history.
But in this case, patient didn't have any family history of the same presentation.
No, do the patient have any symptom of thyrotoxicosis?
No.
I'm sure blood, we have screen. Even the patient clinically, no symptom, no sign, we will still do thyroid function test. I'm sure it was done. So that's why when you present, you say, okay, this patient was first diagnosed with periodic paralysis, how many years ago, was given some potassium and then recovered. So you should actually ask the patient open-ended question. If the patient didn't admit and tell you, or you can ask patient what test was done, then you can ask patient any hormonal test done or thyroid function, straight away tell them any thyroid function test done. So I'm sure they will, the thyroid function test was done. So when you present, you say that on admission, the patient had thyroid function test done, was normal. That means that you know that periodic paralysis, one of the things that you need to look for is thyrotoxicosis. Okay, what else other than thyrotoxicosis? Which can be periodic as well. Anybody know? RTA? Do you know what is RTA?
Renal tubular acidosis. Renal tubular acidosis.
So, how do you want to diagnose RTA? Very simple, right?
Serum bicol.
Yeah. Okay, so I'm sure the doctor also excluded lah. But how do you know that this is not RTA? From the history, how do you know this is not RTA? How do you treat RTA? Or how do you treat hypokalemic periodic paralysis? After you, usually patient come in paralyzed already, you give IV potassium, okay? Okay, you just supplement the patient with potassium. Usually you want very fast, you give IV, sometimes coupled with oral also, and then usually you give mixed KCL and slow K at the same time. But of course on discharge, you will continue with slow K. Usually we try to avoid mixed KCL. Mixed KCL got higher dose of potassium because it's not palatable, it's very salty, patient don't like it. So usually we just give slow K. Okay, you may probably have to give very high dose, 3 tablets, ED or TTS. Okay, or sometimes the potassium is still low, then you have to give mixed KCL as well. But on top of that, if you got RTA, you have to give
Something
bicarb. You know how to give bicarb orally? Have you heard about this solution called Sol solution? Okay, so this is a drug. So that's why you can go through the drug history to see whether this patient has RTA or not. And then RTA got many types: type 1, type 2, type 4. But what we are interested in type 1 and type 2 lah, Fanconi syndrome. Usually they have strong family history. Okay, I diagnosed one family, all of them got RTA. All siblings actually got RTA. You know, some of them no symptom, they don't present with anything. But when you check, they are actually having acidosis, bicarb is low. But some of them come with periodic paralysis because one or two came with one patient came with periodic paralysis. So I screened the whole family. I screened for the RTA, and it was having acidosis. Because when you have idiopathic hypokalemic periodic paralysis, they don't have acidosis. So these are the disease that you need to exclude. Okay, I know if the patient present with the first episode, of course you want to think about Guillain-Barré syndrome, some neurological disorder. But if like this patient recurrent, so I'm sure we will not investigate anymore. We will not even need to ask further history, to see whether it could be Guillain-Barré syndrome or etc. But if it's first episode, yes, a lot of time, it's almost the same like Guillain-Barré syndrome in hypokalemic periodic paralysis. In fact, you have Guillain-Barré syndrome, a lot of time you say one of the differential diagnosis is hypokalemic periodic paralysis. Very easy to make diagnosis, just check the potassium. And potassium is low. Then the treatment is also very easy, just treat the patient with potassium. Okay. So definitely you need to ask about RTA for this case. And so I presume none lah. So this patient is just hypokalemic period. It's relatively common, we see many times. Of course, some patients come in recurrent lah. A lot of times because they default medication, like your patients lah. Because if you continue taking potassium supplement, they should not come in with. Of course, we ask them to avoid high carbo food as well lah. There's a mechanism behind lah. You ask me, I cannot remember already. You must go and read. It's quite interesting lah. They're talking about how potassium, how carbo food precipitate hypokalemia. Okay. Okay, quite a simple case, and interesting. You examine the patient is a lower motor neuron lesions. There are no sensory involvement, just purely motor. Involve all 4 limbs. Okay, so it's a bit like Guillain-Barré, but Guillain-Barré is usually extending. You start with lower limb first, go upper limb, but this one is upper limb and lower limb will be all in. Okay, and then they respond very well to potassium. So usually we just give 1 gram KCL over 1 hour or 2 gram over 1 hour, and then followed by drip with potassium supplement, some slow K, some mixed KCL. Hentam all the potassium until the potassium, then you monitor the potassium probably twice a day until it normalizes. Then the patient can walk the next day, usually, or in the afternoon. Morning you start all this treatment, afternoon patient can start walking. Okay, so it's very typical. Then you, of course, in the first episode, you always check para function test, check BBG to make sure bicarb is normal. And then, of course, you look for other causes of hypokalemia, lah. You know, like patient taking drugs like diuretic, diarrhea, vomiting. All this can cause, but it won't be recurrent unless you say recurrent diarrhea until. But it's very rare for diarrhea until hypokalemic periodic paralysis. Very, very rare. Because the potassium can come very low, 1 point something or 2 point, less than 2.5. Then they will have weakness and all. If it's 2.5 to 3.5 also, usually the patient just feel lethargy. They won't present, we cannot walk, this and that. Okay, quite good case actually. Yeah, good for long case, but you need, as I say, you need to know about hypokalemic periodic paralysis associated with a few conditions like pyrotoxicosis and RTA. And of course, when the first presentation, if it's just weakness, before you actually get the potassium level, you always think about Guillain-Barré syndrome. Anybody want to ask anything about this case? Or anything else you want to tell us about the patient, but nothing much lah. When you examine the patient, I presume patient neurological normal.
Yeah, normal because after testing treatment.
Yeah. So why the patient defaulted then? So you see, this one psychosocial also is very important. Okay, you must ask the patient whether the patient understands the disease. Any family members have the same problem?
No.
Did she know that high carbohydrate diet can precipitate that?
Actually, I asked about this, but I didn't mention in the history. But she said that when she have weakness, usually due to heavy activity, or when she exercise or doing something that cause her to sweating.
Yeah. Definitely, it will be precipitated by sweating, diarrhea, vomiting, as I mentioned to you just now. So, but if you are taking potassium supplement, it shouldn't happen. I'm sure she defaulted potassium supplement also, right?
She defaulted. Only take it during weakness episode.
Correct. So that is wrong. So you must tell her that she need to take every day. What type of potassium supplement was given to her? Is it tablet or is it solution?
Tablet.
No solution, right? No salty, like salt lah. Basically eating salt water lah. No, because you see what happened, like what I told you just now. A lot of patients, they don't like. You give them Miss KCL, it's very salty. They don't like to eat. You don't believe me, you go and take salt water. You take salt, kacau, just drink salt water whether you like it or not. Drink 3 times a day. I'm sure you don't like. So because of that, no, we should try to avoid giving patient Miss KCL. If the doctor giving Miss KCL, that's why she doesn't like, she defaulted, then, you know, you need to give her slow care. But sometimes slow care depends, severity. Sometimes we need to give more. Maybe 3 tablets twice a day or 2 tablets 3 times a day, you know. 3 times a day, very common, patient will forget the tablets. Okay. So these are the things that we need to find out. When you all clerk all the history that the patient defaulted treatment or not following our advice, you all need to find out why. So in your history, you got to say that, oh, this patient defaulted treatment, not good enough. You just say the main reason is because of what? You know, cannot come to hospital, logistic problem, no money to pay for the medicine, or what. So that then in your management, then you say refer social welfare, you know, for financial assistance, or try to sort out the problem. Or what is the problem? You know, asthma patient don't want to use inhaler because not family, usually it's a friend laughing at him or her, you know, when he or she try to use inhaler in the school. Okay, so these are the things that you want to find the reason so that you can treat the patient accordingly. All these are important as well. You know? Yeah. Okay. Any other question?
Prof, if patient is asymptomatic but have mild hypokalemia, are we already start the medication?
Yeah. Usually the patient needs some form of medication. You can give low dose of slow K. Let's say the potassium is too. You see, this type of patient, their potassium won't be more than 3.1. Usually it's very low when they are well. But the thing is, what you do is you give them, when they come in, let's say first presentation, give them IV and then followed by we mix KCl and slow K. So you finally, with the potassium normalize, you stop the drip, stop the mix KCl, just supplement the patient with potassium, a slow K, then you discharge the patient, you check the potassium again. Okay, you want the potassium to be at least normal. Okay, so you adjust the slow K accordingly. And sometimes some of the patients slow K not good enough. You have to give extra mix KCl. So that is the problem. Okay, then you need to teach them what aggravate that. Of course, you are not going to say, oh, don't go for exercise. You exercise, you sweat a lot, then you're going to have hypokalemia, but it's not good, right? So you want them to live as normal life as possible. You can even ask them, when you know they're going to sweat, then you take more slow K lah. Just like your diabetes, if you want to go buffet one day or got kenduri or whatever, you want to eat a lot, you are on insulin, you jab more. Usually you jab like 12 unit, that day you jab 14, 16. So usually we teach the patient how to adjust. They know that you eat this amount of food, sweet stuff, then you have to jab maybe 4 unit more. Okay, you adjust yourself, you try to increase. Let's say usually you jab 12 unit. Okay, now you want to go and makan buffet with your friend. So you jab 14 Okay, then after that, see whether you got hypoglycemia or not. At the same time, you can check 2 hours postprandial sugar. So if we fall between normal range or acceptable range below 7, 2 hours after that, then it's okay So let's say it's still high, 10, 11. So next time you jab 16 you take this amount of food, you jab 16. Okay, but you take less, So like for example, if your sugar, if expect IDDM patient, we always teach them that they adjust the insulin according to food. That's why we prefer them to go for very rapid onset insulin, so that they, especially if they are students, sometimes the lectures, sometimes we teach you supposed to finish at 1 o'clock, we finish at 2 o'clock. So if you jab insulin and you thought that the lecturer is going to finish soon, you jab, then mana tahu the lecturer suddenly talk so much, and then after that you go hypoglycemia in the class. So of course we always tell them, if they are taking this type of insulin, they can preserve some sweet you just take sweet chocolate during the time otherwise you get hypoglycemia symptom. Okay, so the best is rapid onset insulin, jab, eat straight away. So you don't bother about what time your meeting finish or your lectures finish. By the time you want to eat, food arrive, jab, eat. So that is the rapid insurance. You know about this rapid insurance, right? Okay, as opposed to the old insulin, you have to jab half an hour before food. Okay, it takes some time for the insulin level to go up. Okay, so the same thing, you need to see what is the potassium level. If you really want to go for aggressive exercise, then you know that after exercise you get hypoglycemia, hypokalemia, then you take more before, or you give them some mixed KCl, because mixed KCl, the absorption is faster. So when they start to feel weak already after exercise, then they take mixed KCl on the day, so that they will not, until such a bad weakness until need to get admitted to the hospital for IV. You still can treat them with oral. Let's say their potassium, as I say, usually if they are 2.5 and above, they just feel lethargy. They will not paralyze. They just feel lethargy. But once it's 2.5 and below, they can become paralyzed. Okay. And these are going to be lifelong problem. It's not curable. But the thing is, to me, I always tell the patient, it's not really a big deal, You just need to take some supplement, that's all. It's just like you got hypothyroidism, you just tell them this is hormone. It's like hormone replacement. Like ladies will go for Tapso, and then after that you give them hormone replacement. So you don't say this is a disease, but it's actually a disease You just tell them that it's harmless hypothyroidism. Nothing to worry about. They won't die if they continue taking L-thyroxine. You just need to tell them that if they miss 1 dose, tomorrow they take double dose. Thyroxine, you can do this. because it's supra long acting. Today you miss one dose, tonight you remember you take lah. But if you cannot remember tomorrow, say, yesterday I didn't take So you take 100, tomorrow you can take 200 microgram. Okay?
Okay.
Anything else you want to ask me, or any other disease that you want to discuss or whatever? Grand round is for you to, last time we do in the ward lah, so we will go through one by one and then see whether you got any problem on certain case that you clerk and examine. Let's discuss. And then it was my idea also to have grand round, partly also to counter check whether you clerk patient. Last time what we do is we go to the ward, we don't say which one, we just say, oh, this patient, whose patient is this? Can you present these patients? I used to have this when I was medical students, and the head department will take us grand round, but usually not in front of the patient also. What he used to do is he will one Saturday lah, he will someone call me just for a while. Hello? Yes. Okay, fine. I'll see you.
Bukan tak nak screen kan, tapi kes saya tak siap lagi.
Tapi aku dengar dia nak ambil question aku tadi.
Okay lah. Nanti aku tanya Prof. Okay. Bye.
Okay, thank you semua.